All right, welcome everyone. So you're on your way to becoming a pharmacist. And let me tell you, anti-seizure meds are a class of drugs you really need to know inside and out. To truly get a handle on them, you can't just memorize drug names. You've got to understand the whole picture, right? From what's going haywire in the brain all the way to the critical choices you'll be making at the pharmacy counter. And that's exactly what we're going to dive into today.
So, at its core, every single seizure comes down to a simple, fundamental imbalance in the brain. The best way to think about it is like a car. You've got GABA, which is your brain's brake pedal. It's what calms everything down. And then you have glutamate, which is the gas pedal, revving things up and telling neurons to fire. A seizure? Well, that's what happens when that balance gets completely thrown off. It's either way too much gas, not enough brake, or both. And that chaos leads to this uncontrolled electrical storm.
Okay, here's a quick look at our game plan. We'll start with the problem itself, the brain's electrical storm. Then, we'll look at the three main ways we can step in with drugs. After that, we'll get into some cool medchem with molecules that modulate. Then, we'll connect it all from the lab bench to the bedside. And finally, we'll wrap up with what this all means for you, the pharmacist's role.
All right, let's jump right into Section 1, the brain's electrical storm. We're going to really dig into understanding the fundamental problem here.
Okay, first things first, we've got to nail down a distinction that is absolutely critical when you're counseling patients. A seizure is the event. It's that one-time, sudden, uncontrolled electrical burst in the brain. But epilepsy, that's the chronic condition. That's the underlying disorder that means a person is prone to having these seizures happen again and again without a specific trigger. It's a huge point because, as you'll tell your patients, having one seizure doesn't automatically mean someone has epilepsy.
So, what's actually causing the epilepsy? Well, it's not just some random thing that happens. It can be triggered by all sorts of things. We're talking structural damage from a brain injury or a stroke. It could be genetic, mutations in certain ion channels, a classic one being SCN1A. Sometimes it's from an infection, or even metabolic or immune system issues. And yet, sometimes the cause is unknown. But knowing the why is so important because it gives you, the pharmacist, crucial context for that patient's entire health picture.
Okay, so now we get the problem. Let's move on to the solutions. Section 2 is all about the three main ways we can intervene. These are the core pharmacological strategies we have in our toolkit.
When you look at the whole landscape of anti-seizure medications, or ASMs, their mechanisms really boil down to one of three main strategies. First, we can block the ion channels that neurons use to fire. Think of it like putting up a roadblock to slow down that electrical signal. The second way? We can enhance GABA. That means we're basically pushing down harder on the brain's brake pedal. And the third strategy is to inhibit glutamate, which is like easing up in that gas pedal. It's all about restoring that balance.
All right, time for a little medchem. This is where things get really cool. We're going to look at molecules that modulate through a really neat case study, showing how scientists can take a good molecule and, over time, make it great.
And that story is the evolution from carbamazepine all the way to S-carbazepine. We're going to trace the history of this one class of drugs, the aminostilbenes. You'll see how chemists made these tiny, clever tweaks to the molecule, creating new versions like oxcarbazepine and S-carbazepine, where each new generation was specifically designed to fix a problem the last one had.
Check this out. This table tells the whole story. You start with carbamazepine. Great drug, but it had issues, right? It creates this active and kind of toxic epoxide metabolite, and it's a huge pain because it's an autoinducer, meaning it speeds up its own metabolism, so dosing is tricky. So what did the chemists do? They created oxcarbazepine. By tweaking the structure, they changed how it's metabolized, getting rid of that autoinduction and making it way better tolerated. But they didn't stop there. The final step, S-carbazepine, is just brilliant. It's a prodrug, which means it gets converted to the active form in the body, leading to simpler, once-a-day dosing and even fewer drug interactions. It's a perfect example of smart, iterative drug design.
Okay, so that's the science, that's the chemistry, but what does it all mean for the actual patient? Let's bridge that gap and go from the bench to the bedside.
You're going to hear about these side effects a lot. Most of these drugs work on the central nervous system, so it makes sense that the side effects are things like dizziness, drowsiness, that kind of mental fogginess or cognitive slowing. Patients will tell you they just don't feel sharp. Your job is to counsel them that this is common, especially when they're starting a new med or changing the dose, and that you're both working to find that sweet spot, the best dose with the fewest side effects.
Now, this is a big one. This is where pharmacology crashes right into genetics.
Some of these drugs, especially carbamazepine, come with the risk of truly life-threatening skin reactions like SJS or TEN. And it turns out the risk isn't the same for everyone. It's dramatically higher for patients who have a specific gene, the HLA-B1502 allele, which is much more common in people of Asian ancestry. This isn't some futuristic idea. This is today. Pharmacogenomic screening before starting this drug is an absolute necessity. It's how we prevent a catastrophe.
Okay, drug-drug interactions. As a pharmacist, this is your bread and butter. You have two main players here. You've got your potent inducers, drugs like carbamazepine or phenytoin, which are like hitting the fast-forward button on metabolism for other drugs. The clinical impact? Huge. It can cause other meds like oral contraceptives to just completely fail. On the other side, you have potent inhibitors like valproic acid. These guys hit the brakes on metabolism, which can cause levels of other drugs to spike, leading to serious toxicity.
So let's put this into practice. Picture this. A 28-year-old woman comes in, she's on oral contraceptives, and she needs an anti-seizure med. Which of these three is the biggest red flag for contraceptive failure? Levetiracetam, carbamazepine, or lacosamide? Think about it. If you landed on B, carbamazepine, you are absolutely right. Why? Because it's that potent enzyme inducer we just talked about. It's going to chew up her birth control, rendering it useless. This isn't just a trivia question. This is the kind of clinical intervention that prevents a life-changing adverse event.
Okay, let's bring it all home. What is your role in all this? You are the final checkpoint in patient safety. Let's talk about what that really means.
Ultimately, the goal of therapy is always this tightrope walk. On one side, you have complete seizure freedom. On the other, you have minimal or zero side effects. Finding that perfect, delicate balance, well, it's more of an art than a science sometimes. It takes careful drug choice, slow titrations, and constant monitoring. And you, the pharmacist, are a central part of making that happen. So what are your critical responsibilities? It's a long list, and every item is crucial. You're monitoring for both efficacy and those adverse effects we talked about. You're constantly screening for and managing drug interactions. You're counseling on adherence. A single missed dose can be a seizure trigger. You're educating patients, especially women of childbearing potential, on all the risks and benefits. And you're helping them navigate dose changes, both up and down. You are, without a doubt, the patient's final safety net.
So, I want to leave you with this question. Right now, let's be honest, picking an anti-seizure med can sometimes feel like a bit of trial and error. But the future is all about precision medicine, right? With everything we're learning about pharmacogenomics, we're getting closer. So the real question, the challenge for your generation of pharmacists is this: how can we get better at predicting the right drug for the right patient from the very beginning? How do we nail it on the first try? That's the puzzle you get to help solve. Thanks so much for diving into this with me today.